going to turn it over to you.
Thank you so much. I appreciate it. So first, I just want to say thank you for joining me in this somewhat unusual way. I'm very disappointed not to be with you there in Tampa, but do appreciate the fact that all of you, who unfortunately I can't see, decided to come to the session anyway. And so I'm looking forward, especially to the Q&A session, and to hear your thoughts and questions and suggestions, if you will, when we get to the end of this. But what I'd like to do today is spend a bit of time talking about a topic that I've been asked about quite frequently, which is hospital of the future, and just sort of work our way through kind of where we are today and where we're headed and how we might get there. What are the strategies and tactics we as the HTM professionals may be able to employ to move this forward. So with no further ado, let's move on. So spoiler alert, for those of you that came thinking I'd be talking about a lot of cool new technologies and medical devices, no, I apologize. Hopefully no one will leave, but that's not what we're really going to be talking about today. Excuse me. Instead, what I'd like to do is really talk about what is the hospital, because I think what you're going to see is that we're going to have to move well beyond the hospital. Things that we are familiar with, like academic and community hospitals, public hospitals, critical access hospitals, something that we've heard a lot about recently, if you will, the critical access hospitals. Pardon me. All of these are, depending upon where you work, maybe hospitals that you're familiar with. But it's really time for us to move beyond even the hospital and talking about the hospital of the future. And about a year ago, the CEO of Baylor Scott & White, and there may be some folks in the audience there from Baylor Scott & White who know, or at least know of, Jim Hinton. And in the course of an interview, he shared this quote that there really isn't a hospital of the future. It's a health system of the future that we need to be focusing in on and understanding and refining and adapting to today's world. And this quote really caught my attention because it's something that I've felt actually for the better part of my career. When I started as a staff clinical engineer back in the early 90s, in my first real job after school and internships and whatnot, it was within that very first year that I joined a hospital that we started the process of merging with other hospitals and building out other facilities. And so the health system of the future really has been underway for decades, but it's sort of hard to notice it. It's kind of one of those forest for the trees things. And so when Mr. Hinton said this quote or had it published in the article from his interview, it really caught my attention and thought, we really do. We have to look beyond the walls of the hospital that we serve every day to what is the larger community, if you will, that we serve. So it sort of begs the question, what is a health system, right? Lots of us as HTM professionals do not get a lot of this sort of information unless we're reading it ourselves or we happen to have a relationship with the hospital administrator or something along those lines. But it's important for us to understand that health systems really are the whole continuum of care. And again, that's a phrase that maybe is not familiar to everyone, but it's that whole range from primary care all the way through end of life care. And these are just a few images that I was able to find on the internet that sort of convey that idea that it's the one in the lower right corner says it's that continuum of illness through wellness and wellness through illness, and the various places that patients find themselves, excuse me, throughout the course of their life, if you will. And remembering that all of us are also patients too. So while these words in these continuums or these phases may not sound real familiar from your professional life, they probably feel fairly familiar from your personal life, addressing your own health needs or those of your family. So it's important for us to sort of have these images in our mind as we think about what does a health system look like. And the reason I have the map there on the left-hand side is because most health systems now are across at least 2, if not many states in the United States. And some of our health systems even are international today. I was just talking with a colleague recently who was sharing some insights of how their health system has expanded into the Middle East, and others have expanded into Europe. And so it's important for us to understand it's not just that one building that we go to each day when we report to work, but that one building is part of a much, much bigger system that is taking care of patients or prospective patients, those that are healthy, if you will, across a large geography. And so this really makes us have to sort of stretch our brains to think about, as HTM professionals, the work we do, how does that play into this? So to begin that thought process, I found another article as I was searching through sort of what does that really mean? What are these health systems? What are the drivers behind these health systems? What's keeping the C-suite up at night, if you will? What are the things already being put in place? And I came across this article, and I promise you I have a link to it later so that you can read the full thing. It's a pretty good article from Deloitte and their Center for Health Solutions. But they propose that the hospital of the future, or even the health system of the future, is perhaps already here. It may be young, it may be in its infancy, if you will, or maybe a toddler learning to crawl. But a lot of these things are already in place. Health systems, and you're a part of these, you're probably seeing these in your day-to-day work already. The business models are changing, right? The types of care that are required, the types of staff required to take care of these complex patients and to deliver the complex procedures is changing. Some of you may have health hubs. Health hubs are things, and I had the opportunity to work with them in my last position, are locations that often look a lot like a hospital. They operate many times 24/7. They have procedure areas that look very much like ORs. They have imaging areas. They have full laboratories. They look very, very much like a hospital. However, some of my non-HTM, non-clinical colleagues will say they have no beds. Well, they do have beds, they have physical beds, but what they mean is they're not licensed for reimbursement purposes or for licensing with the government for payment or construction or accreditation as having beds. They're licensed as outpatient centers. So I think many of you have probably had family members, or maybe you yourself have had a surgery that was 10 years ago, 15 years ago would have been done in the hospital, is now done in an outpatient center. These hubs bring all of those sort of separate, disconnected outpatient centers together into a hub so that they can work more tightly in an integrated fashion. And so we're seeing these pop up from many health systems. Probably over the last 10 years or so, we've seen many of these pop up around the country because hospitals are very expensive and these hubs are less so, and balancing reimbursement issues, which we'll get into in a little bit. And then, of course, the hospital at home. We hear a lot about this. We've heard an enormous amount about this over the last 8 months or so as we and the world have dealt with the ramifications of this pandemic. Finding ways to take care of folks at home, whether they're mildly ill or more critically ill. How do we create a virtual hospital sort of environment in someone's home when we cannot bring them into or determine not to bring them into a traditional hospital setting? All of these things are in motion today, and we sometimes think of these as things out in the future, but they're actually happening today. And then these other care delivery disruptors, you guys know there's data everywhere. We have more data buckets and backups and redundancy than ever I personally imagined. AI and machine learning are both just everywhere. It's pretty exciting to see how folks are trying to use these technologies. We've actually had these around. We may have called them different things. I always like to remind my HTM colleagues that yes, AI and machine learning are incredibly cool and they're sophisticated, but those of you that were around with me and before me in the 80s and 90s will recall arrhythmia monitoring, right? And how many of you in the room had the responsibility of evaluating arrhythmia monitoring systems for your hospital at the time, and all of the tapes and loops back in the day that were used to train the monitoring system to identify arrhythmias in patients. So that was a very early form of what we see today happening at just lightning speed, if you will. And then certainly robotics are not new to us. We've been in the robotic surgery business for many years, and we're seeing robots do more and more functions in the hospitals. And I think that will just continue, especially as we look at this new era of infectious disease that we find ourselves in. This is just Carol speaking. I don't think we're on a 100-year plan anymore. I think because we're such a global society, we have to be aware of these sort of situations and understand how to manage them when they arise. And hopefully someday we'll have the ability to minimize, if not avoid them completely. And some of that may come through the Internet of Things, which I know every single one of you are dealing with in your hospital as we talk about the whole cybersecurity world. So these are just some examples that say when we talk about the hospital of the future or even the health system of the future, because all of the things on this page are not just in that one building, but they're interconnecting all of the buildings, that whole continuum of care, excuse me, that we were just talking about. To create the system, if you will, across these different facilities. So where does that leave us as HTM professionals, whether you're a technician or an engineer or a manager? The world you entered when you came into this field has probably changed pretty significantly. And so that sort of career plan and professional development and technical development, all these things that we focus on, you know, what do we do now? How do we continue to make ourselves relevant and valuable to our organizations to move us forward? And I think that's a question all of us have to ask ourselves every day, because I know the technical things I need to learn each day are a bit different than they were when I started or in the 90s or even in the early 2000s. Things are very different today that I need to learn. And if I were today managing, I was managing staff just 5 years ago, and the things that we had to deal with as managers was very different than what my management role was in the mid to late 90s. So we need to make sure that we are staying agile, and aware of the circumstances around us. And I think my slides are jumping. Okay, so we want to make sure that we don't end up in this place, right? So those of you that have heard me talk before, sorry. Those of you that have heard me speak before, or even just in our one-on-one conversations, know that this Venn diagram is sort of in my brain all of the time. Where is that point of intersect between the clinical, technical, and financial world? And I think all too often we find ourselves sort of just gravitated and anchored into that technical region because that's where we're comfortable, right? We're technical types. We're trained as technicians and engineers, and we study the electrical and pneumatic and chemical systems and all these sorts of things, and we're really comfortable in that space. The problem is we really need to be right there in the sweet spot, right? We don't need to be clinicians, but we need to be more involved with our clinicians, and we need to be thinking more about their world. And we don't have to be financial experts. We don't have to move to the finance department. We don't have to move to the supply chain department or any of the other business driven. but we need to understand their business a bit better. We need to figure out how to bridge gaps and move us all towards that sweet spot where the optimal decisions are made for our organizations. And remember, and ultimately, the whole reason all of us have the jobs we have is to take care of those patients that are somewhere on that continuum of healthy to end of life. So I was fortunate enough to have internship directors that pointed this out to me probably day one. And I apologize at this point. I don't remember whether it was Bill Betts or Manny first. They were my directors. But they shared this with me. They shared that as a clinical engineer, my job was to build those bridges. Yes, I came to the game, if you will. I came to this healthcare world as a clinical engineer, as a technical person. I have all that technical education and training and background in my pockets, if you will. But my job really was to bridge that with the clinical world and the business world, which meant a lot of my internship experience was spent learning more about those areas, understanding their worlds so that I could build bridges and tie the pieces together. And oftentimes observe my directors or the technicians or the other clinical engineers I worked with, not just bridging the technical world to clinical or technical worlds, but also helping build bridges between between the business or financial worlds and the clinical worlds. That really, as a HTM professional, you have a unique opportunity to be a real convener and help pull all of these together into the sweet spot. So the question I always get is, well, how do I do that? How do I get there? What do I need to understand in those worlds? And I will share with you that I am still learning. That's the beautiful part about being in HTM, is that every day is an opportunity to learn something new, to experience something new. So what I'm going to share with you here in the next several slides really is more about the lessons I've learned and the resources I've gathered along the way. And hopefully, and when we get to the Q&A part, all of you can share some additional ones. So let's start where we all started to begin with. And by that, I mean where our profession started, which was at the bedside, right? So probably back in the 50s and 60s timeframe, there were clinicians, physicians, surgeons, looking to take care of patients in hospitals. It was not a medical device intensive era, but they felt they needed tools, and they brought engineers, traditionally trained engineers and technicians, to the bedside to create the electromechanical devices that began developing in those early days. And that today it's hard to imagine them not having always been here, right? But as this technological environment accelerated, it really required our clinical partners to put a real focus around their clinical protocols and clinical practice guidelines. So how do they practice medicine? Whether that's the physicians or the nurses, or how they come together, much like we come together with our various roles in HTM. And so in their various clinical areas of expertise, cardiology, respiratory therapy, pulmonology, surgery, radiology, all of the ologies, if you will, have clinical protocols. When it's this condition, we do these things. You'll often hear the phrase evidence-based medicine. Evidence, that's all those clinical trials, that's all those studies, and we're very familiar with those over the last few months as well, with the various drug protocols or drug trials and how those turn into protocols. And same thing with medical technologies. When and how do you use the various sorts of technologies? And then their practice guidelines all the way down to the front line, sort of the step-by-step, almost like a PM procedure, if you will, right? But it's the clinicians and how they interact with patients with certain conditions. Now, early on, when I first got into the field, I spent almost all my time in the clinical environment, as did the technicians and other clinical engineers. We were in and out of clinical areas, ICUs, medical surgical, the ORs, radiology, wherever. We were in and out of these environments all the time, and not always doing a repair and install. We might be doing a construction project. We might just be checking in. And over time, partly because we've all become extremely busy, and for a host of reasons, we've all too often disconnected from our clinical departments. And so recognizing and being familiar with clinical protocols, not to do them, but to be aware of them and how our work connects to them, has really fallen to the side. I've observed in a number of situations. And sort of a personal example, the reason I'm not able to be with you guys today is I am helping to manage a personal family critical healthcare situation. And what I've realized in this particular case is that an area that I thought I was very familiar with, I've actually fallen behind. And I'm not as aware of the sort of clinical protocols. And this is a space that I was very familiar with, 15 years ago. And so shame on me, right? I've sort of lost, I focused in other areas. And so I'm having to scramble a bit. And you know what, that happens, right? Because medicine is huge. But if you have some areas, if you think about where your assignments are and you make sure you're really solid and have the conversations with your local clinicians, understand what are the protocols in your facility, what are the practice guidelines in your facility, you will be able to match the tools for them in a more effective way. And then if your assignment changes, say you were in cardiology and now you're servicing more of the OR, same thing, take the time, invest the time to work with them, have conversations with them, just observe them and see what they do and how they do it and ask questions, sort of put yourself back in that student role again and ask the 5 whys, if you will. At the bottom of this page, and you'll see on some of the future ones, I'm going to do the same thing. I've provided you with links to some of the clinical professional organizations. This is a great way to see what is top of mind for them. Some of these actually have protocols and practice guidelines that are considered national, if you will, and just guidance to help bring you up to speed. So I encourage you to look at all or some of these to really sort of up your game, if you will, and to inform yourself. Now, on the more business side, if we start transitioning around that Venn diagram to more of the financial and business aspects, how do we make ourselves more familiar there? The first group that I would encourage you to get to know, if you do not know already, is supply chain. They, like us, have sort of a 5 rights mentality. And I adapted this many decades ago from my pharmacy and nursing colleagues, and I'm thrilled to see that so many others have really adopted this thinking as well. But the 5 rights of HTM are really to have the right technology in the right place for the right patient, wrapped up with the right technical management program to ensure the right patient outcomes. It's really, if you can see that knitting together of the technical and the clinical, and that whole wrapper is the business financial part of making sure all the pieces are where they need to be, the logistics of it, if you will. And the management program is really, can I be from a quality and a financial perspective on target to make sure that I'm helping enable positive patient outcomes here. This is really a fascinating area from a systems of systems engineering sort of perspective. I can promise you that if you will spend the time to learn about this area, you have huge opportunities to contribute and partner and collaborate, because the way we see the world as technically trained folks is very different than the business trained folks that are in supply chain. And together it's sort of like jet fuel, if you will, for the health system when we can partner together, because we can find the efficiencies, we can find the opportunities that have the biggest bang, if you will. And so I would direct you to this group, the Association for Healthcare Resource and Materials Management. I was just on the phone with them a couple of days ago talking about an opportunity to connect our areas of expertise and move some things forward. The supply chain world is working just extremely hard right now, as many of you probably know, in terms of the whole, how do we get products into our health systems in the midst of a pandemic, right? They're doing incredible, fascinating work, and many of you are probably working hand in hand with them. So take this sort of horrible situation and find the silver lining in that you're building new relationships here and you're learning new areas of expertise to really, again, supercharge the work you do and to supercharge the collaborations and relationships you have in this space. Because I think there's huge opportunity in this larger health system. You may be feeling it in your hospital, but as we move forward in this pandemic and beyond the pandemic, we're really going to see, I believe, the impact and the interrelationships of all those pieces of the health system that we talked about, or that I talked about earlier, coming together. And we will have learned a lot of things here that we will then be able to expand out and grow and mature to a broader part of our health system, if you will. And then the money. Whether we like it or not, all of us got into this business because we wanted to make a difference in the world. And we wanted to make a difference in the lives of people that were, as a colleague recently said, we're in the hospital when people have their very worst moments and their very best moments, right? And to keep doing that, to be able to keep doing that, the nun said, probably 100 years ago, because healthcare started as a faith-based mission sort of effort, was there is no mission without a margin. You have to make enough money to keep the doors open. We have to make enough money to pay our staff and to have the technologies and to have the pharmaceuticals and all the things that we need to deliver care. And there is a very delicate balance and a complex dance that our colleagues in finance must do. And so there's some terms that I've been studying over the last probably 10 plus years, 15 years, trying to understand. And they were, again, fortunately, they were introduced to me very early. At least the first two here were introduced to me very early in my career by a nursing manager. Again, see, I'm out in the units and asking, what do you do and why do you do it? And in the course of that conversation, she intermixed the need to understand payer mix. Now, if I was in the room, I'd ask how many of you know what payer mix is, and do you have a sense of what it is in your organization? So since I can't do that, I will just bear with me a minute. Payer mix is really, how does your organization get paid? It gets paid by the federal government. It gets paid by private insurance. It may or may not get paid by private individuals who pay cash out of their pocket. It probably gets paid by the state, and it may get paid by other sources as well. It probably, but the big payer mix view that most organizations have is Medicare, Medicaid, private insurance for individuals, and private insurance at the group level, which is like employer-based, if you will, insurance. And as you may or may not be aware, both professionally and personally, they pay differently, right? And each one of those has probably 100 different plans, right? And so your finance department is sorting through this whole mess of their payer mix. How many Medicare, how many Medicaid, how many private insurance, what type of private insurance? And so when they talk about the payer mix, they're looking at where their sources of income are, just like any business would need to do. Now, the situation becomes more complex today because over the last at least 10 years, 15 years, maybe more, I lose track of time, we have moved from the traditional fee for service. Every time I do something, I get paid. I send a bill and I get paid by one of those elements of the payer mix. That has been the way medicine, or the healthcare system, has been financed, if you will, for hundreds of years. The change now, and I know all of you have heard this because it's on the news, every news outlet channel that I've ever listened to, talks about the new payment systems. And they're referred to as value-based care or value-based contracting, you may hear. And this is more of the pay for quality, pay for outcomes. And so today, most healthcare organizations are straddling these two worlds. So when you and I as HTM professionals are asking for money, whether that's to operate our department or to buy new equipment, the finance folks are looking at where is all our income coming from? Is it coming? And how do we as an organization decide how much we can and should spend to operate our business, and how much can we set aside for capital, whether that is constructing new buildings or implementing new technologies, a host of different, and technology could be IT, it could be pharmaceutical, sort of new pharmacy systems, big technology like the robotic systems. It could be any of those sort of capital worlds, if you will. So having at least an overview understanding of how the finances, how the money works, if you will, in your health system is pretty important for you to maybe sometimes. For me, it was helpful for me to manage my own expectations, right? It was also helpful to me as a person, as a consumer, to understand the complexities of the healthcare environment as I manage myself, my family, and my extended family. But it's certainly helpful in the workplace because you begin to understand the difference between the operating dollars to just run the business day to day and the capital world, and how the income impacts both of those. And oftentimes there's simplistic but reasonable analogies to how you may run your own household. So spending some time, and again, lots of references here. First and foremost, I would recommend that you spend some time on the CMS.gov website. Side note, many non-government insurance coverage reimbursement sources follow the lead of CMS, what the government approves. Not always. Occasionally, one of the Blues or the Aetnas or one of these other payer organizations, the insurance companies are referred to as payers. Sometimes these other payers will drive the thinking, if you will, about what procedures, medications, what type of coverage will be paid for. But predominantly, it is driven by the federal government's, the Centers for Medicare and Medicaid. So I encourage you to spend some time there. I will share with you too that in these other three that I have on here, these are the C-suite. You know, when we as HTM professionals talk about the C-suite, it's these three areas. HFMA, that's the finance people, that's your CFOs. The College of Healthcare Executives, these are your COOs, your CEOs. There's probably CFOs and chief nursing officers and all the other C's in that group too, but it is heavily weighted with your CEOs and COOs of healthcare. And then the Organization for Nursing Leadership, these are your nurse executives, your chief nursing officer, whatever title you happen to use. And so getting in there and seeing what is important to them, what are the drivers for them at that executive level as they make these difficult decisions about what is our market share, how do we manage it, where should we provide services, where should we not go with services, who should we merge with, who should we avoid, all these sorts of things. You'll see a lot of that thinking in these resources. They'll at least get you started. Okay, take a breath. So let's bring it all back together now. And so while this session was titled The Hospital of the Future, yeah, I apologize, I lied to you. It's really the health system of the future. And it is the hospital that we're all very familiar with. It's the outpatient clinics and facilities that we visit to provide service. But it's also areas like skilled and long-term care facilities. It's the home, that center part of this diagram. And I want to make sure that we don't forget, and you'll hear this from our clinician partners every single day, is that the patient is at the center of that. And we have to remember that the patient is first and foremost a person. And that's a little easier to do if we remember that we are simultaneously in the provider world, but also the consumer world. We are ultimately patients as well. And so keeping the patient at the center, which you'll hear frequently, makes it a little easier to see how these other pieces wrap around, if you will. But I'll share with you again another personal story, and it relates to why I'm not there with you today. In the particular circumstance, actually I have two different ones to share with you. The skilled and long-term care facilities are an area that I personally believe we need to sort of poke our head into and get more familiar with. I have two situations. One, I had a family member who had a hip replacement revision. So they had their hip done several years ago. They had to come back and have it fixed again, if you will. And because this family member was in their 80s or so, and their spouse was also in their 80s, rather than going straight home from the hospital, they went to a skilled nursing facility. And when you look at the staffing levels in skilled nursing facilities and the technology they do or do not have, and the capabilities, the training that they do or do not have, it is night and day from your hospital environment. So if you've visited one of these areas, either professionally or personally, there is a stark, oh my gosh, this is way different, right? And so I think that's an area that we really need to understand. In that case, it was a very orthopedically driven situation and concerns about the patient and their ability to basically not get hurt in this environment, but still be mobile as part of their care. That's back to the clinical protocol understanding. These patients have to be mobile for the orthopedic intervention to be effective. My second example was a more critical family member who is on a ventilator and has been for a considerable time, has been bouncing between the traditional hospital environment, med-surg units, and ICU units. Those of you that don't have ventilators in your med-surg units yet, it's coming. At the hospital I worked at in the 90s, we were putting in alarm systems for ventilators on med-surg units. And so I would be kind of surprised if you don't already have them. But then there were the trips to skilled nursing. Well, skilled nursing facilities oftentimes are not prepared for ventilated, highly complex patients that bring technology with them. And so you end up in situations where health systems, you have to bounce between from health system A to health system B, because health system A does not have a skilled facility that can care for patients with ventilators, or they don't even have the physical infrastructure to support ventilated patients. You guys know what that takes, all the electrical and the air and all of that, right? And then there's a type of facility, the long-term acute care facility, some of you may be familiar with, which is licensed not exactly like a hospital, but sort of like a hospital. And so you get into these weird reimbursement situations. But they are supposedly capable of taking care of more technologically complex patients. I'll share with you that's not always true, whether that's the facility or the staff or some combination thereof. So there are areas that desperately need our participation to help inform, not to direct, but help inform, so that just as we've done over the last many, many decades in the hospital and outpatient clinics, and are dabbling in the home, we have to help that sort of far right-hand side there, the lower right-hand skilled and long-term facilities and home. We need to participate more in terms of how those develop technologically and not wait for them to show up. We're going to have to invite ourselves to those conversations to inform, because remember, we're that bridge between the technical, the clinical, and the business financial areas. And so that really puts us in a place to really think about the whole continuum of care of a health system. But the one last layer I'd like you to think about, and many of you, if not all of you, have probably been reading about this as well. A lot of health systems are looking at, and I'll tell you, CMS is looking at this as well. All of the payers are looking at this, which is what are called social determinants. And that's that ring outside. These are the things that I don't normally think about when I'm doing my HTM work. Again, sometimes it takes the personal situation to bring it home again, if you will. But as our health systems begin to, or have been looking, how do we really live into our mission, which is to provide affordable healthcare to the communities we serve. That's the key phrase there, the communities we serve. Well, what's happening in those communities that determine, what are those social determinants? What are those things in the community that determine where an individual is on that continuum of care, right? Do they have food? What kind of food? Probably heard the term food deserts, right? You can be living in the middle of the city and not have a good food source anywhere near you. I've lived in places like that, or near places like that, and it changes how you live. What is your shelter, right? We know that people live in all levels of homeless shelters through mansions, right? And employment. We've heard a lot about employment this year. All of us feel employment every day, right? Whether we have it or we don't have it, or we sort of have it. Education is a huge determinant. Do people do they have the education to know what's going on, how to get some of these other aspects of their social world? Do they know how to access healthcare? Do they have just the basic fundamentals of education? And then the general culture, where we all come from, our immediate family, and through our whole ancestry.com kind of thing. We all come from a little bit different culture, and they've been merged and mixed. And so it's important for our health systems to look at all of these social determinants, that's what they refer to them as, in the process of designing what should our health system look like. What sort of pieces in the middle there do we need to wrap around the patients or the potential patients, the people that are healthy and we're trying to keep them healthy? What do we need to wrap into our health system to deliver the care that they're going to need over that whole continuum? And maybe it's partnerships. Maybe we don't do it all ourselves. We have to make those buy versus make decisions as a health system company. But what is that whole system or system of systems that we need to construct? And I believe as health system, as HTM folks, we can participate in that conversation through things we do every day, like strategic technology planning. What kind of technology do we already have? How could we redeploy it? Where are we heavy? Where are we light? All that sort of guidance. Being involved in the actual acquisition process. The acquisition process, our repair and maintenance, and our disposition processes, those help keep the doors open, right? Remember, when we understand kind of how reimbursement works, where the money comes from, we can better understand what role we can play to say, how do we make best use of the few dollars we have? How do we make really good use of that? And we can't do it in our bubble. We have to do it in this collaborative way to understand the big picture of what are our clinical protocols, what are our financial protocols, and then see how our technology and technology protocols will enable that and help drive it forward. So with that, I am going to give you this page of further reading. There's the Deloitte article that I spoke about earlier, and several more. These are ongoing news feeds. Some of these you may already have. Some of them may be brand new to you. All of these you can get at least a baseline free dump into your email, daily, weekly, monthly. All of them, I believe, have deeper subscription things you can do if you like. But for the most part, I think on most of these, I get an enormous amount of information just from the free feeds that come in and help keep me aware and informed. So I will leave this with you along with all of the other resources. And let's shift to questions and comments, because I'd love to hear what others are thinking and doing.